We're here to talk about
Burnout.
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 burnout. Burnout. It's a word we hear constantly in medicine, but it doesn't look the same in every specialty. In this series, we bring together physicians from across medicine to talk about what burnout really looks like in their field. This is Burnout by Specialty. Welcome to Burnout by Specialty. This is our internal medicine episode hosted by doctors on social media. My name is Mary Ramon. I'm a licensed counselor and coach for physicians, and I am so grateful to have three internal medicine physicians here today. We have Dr. Dami Babanici, Dr. Robert Duhaney, and Dr. Diane Shannon. Welcome. Let's start with brief introductions. Dr. Babanici.
Yes, I'm so glad to be here. Thank you all for having me. My name's Dami Babanici. I am a hospitalist in Dallas, Texas, and also work as the medical director for clinician well-being for our medical group. So glad to be here.
Welcome, welcome. Dr. Duhaney.
Yeah, I'm glad to be here as well. So my name is Robert Duhaney. I'm a internal medicine physician. I practice primary care in Austin, Texas with One Medical. It's a national primary care group. And I also do some consulting for hospice and other uh, agencies.
Thank you for being here. Dr. Shannon, welcome.
Thank you. Great to be here. So I've had three careers so far in my 30 years in healthcare. First was internal medicine primary care, burned out. So my second career was 20 years as a healthcare writer, writing about our healthcare system to try to understand why I burned out. And then most recently, for the past 7 years, I've been a full-time coach for physicians, helping them to create sustainable careers so they can stay. And I'm located in Boston.
Thank you very much. Well, let's get started. Dr. Babanici, this one is for you. What does burnout look like in internal medicine compared to other specialties?
Well, that's a great question. Because I haven't worked in other specialties, I'm not going to be able to speak on their behalf. But for us in internal medicine, which internal medicine, you can be outpatient, inpatient. I'm going to be speaking from the inpatient side of things. For a hospitalist, I'm an academic hospitalist, and I get the pleasure of teaching medical students as well as residents. And sometimes I'm also on the private service. So on the private service is where I'll say you do have the risk of running into burnout more because you carry more of the load by yourself. It's an onslaught of admissions, rounding, paperwork, consults. So I feel like burnout from an in-person standpoint is being pulled in so many directions that you don't have a centering sometimes, and you get frazzled because your attention is demanded in so many ways. And so there's this misalignment between what you want to do and what you're actually doing. So that definitely creates a recipe for burnout. And admin, if we want to add admin parts to it too, and paperwork and meetings and committee assignments, all the things that can just keep adding on. Yes.
That's a lot. Dr. Duhaney, what would you say? What part of the job is most draining?
But I'm coming from it from an outpatient perspective in the clinic. I mean, when you go into primary care, typically you have a high desire to want to build relationships with patients and you love that aspect of it. But oh gosh, there's so many different things that can be draining about it. One particular thing, and I know a lot of physicians agree with this, is the prior authorization process when you know you want to implement a treatment plan, a medication, get some imaging done or whatever the scenario, but there's a roadblock from the patient's insurance saying, oh, they need to go through these steps. They need to do this first. Even when we know that they're going to end up needing this eventual thing that we've actually prescribed, we've got to go through these steps. And I think it started out, with the intention of it being, let's control costs, let's make sure we're not doing anything that's not evidence-based per se, but it's gotten way out of hand. Basically, it's just become this giant block on patient care, and it really drags us down. And at One Medical, we have a remote admin team that kind of helps us with prior authorizations. But you can imagine when the GLP-1s have come out, and it's become this whole thing with weight loss, and they're great medications, but you can imagine all the prior authorizations that we've had to go through, get some of them covered, most of them not covered, but it's just the burden of that alone really slows down patient care. And then the patients kind of feel like, well, is it because you don't want me to have this? It's like, no, no, it's not me, it's the insurance. So it gets in the way of our relationship with the patient.
Thank you. Dr. Shannon, from your perspective, what do people outside of internal medicine not see?
I'm not sure that they don't see it. I think because so many of the stressors are common to different specialties. Now, there are some specific, obviously, and that's why we're here. But what I found, especially in the groups that I run, that physicians hear about another person's challenge and like, oh my gosh, I didn't realize that you also were spending 3 hours every night on charts or whatever. Obviously, that's not true for more of the surgical specialties. I think when it's procedure based, often you can do your notes right away and the procedure note, and then you don't have as much communication going back and forth in the patient portal. So I think those are some of the things that the burdens that maybe, like you said, other specialties might not have to the same degree, but I think they have them too. But in terms of notes are huge, prior authorization, and I think just the ongoing relationship with patients, which many internal medicine specialties, both general internal medicine and subspecialties, have that ongoing relationship with patients. And when you can't do what you know is right, for whatever reason, there aren't enough resources, the staffing, or the insurance payers are not coming through. It is a really difficult, and it strains that relationship when you want so much to do what the patient really needs, and there are roadblocks.
Thank you. Some people say that leads to moral injury. Appreciate that. Dr. Babanici, again, let's think about system pressures. Where do system pressures hit you hardest in internal medicine?
Oh, that's a great question. Speaking from an inpatient standpoint, because you have to have a hospital that's functional, and even though I'm in a level one trauma center, so it's really busy, and we're also a safety net kind of hospital, so we get a lot of referrals, a lot of patients that come in through the emergency room too. So bed availability is always a challenge. So you have a group mix of patients that are really sick, and we're also a transplant center. We're everything. You have patients that are really sick and patients that need to come in. So you have to kind of do that dance of trying to make the beds available. So sometimes, and this is really not blaming one person or anything, it's just, you get the pressure of, or you need to discharge patients. You need to discharge patients. Well, if they're not ready to be discharged, or if you've not even had time to see them because your census is so big or they're so sick, then you're like in this rat race of trying to get people out to get more people in when you're not sure and ready that these patients are even ready to leave yet. So that would be the one big thing that I would say can add a little bit of pressure because you're trying to deliver excellent care, but also trying to make sure that you can admit patients into the hospital safely. So, and also want to discharge safely. So that could be a little bit of pressure. And there's sometimes, I mean, which we don't do that as much anymore, but the pressure to discharge before a certain time could add that additional pressure to the physician because I'm trying to think clinically, but I'm also trying to meet this goal, and that's how the system can add to the pressure of being a doctor.
Thank you. I love your three unique backgrounds because even within internal medicine, the pressures are different. So, Dr. Duhaney, what feels most unsustainable? You mentioned prior authorization. Is there more?
Well, Diane, I think you may have touched on it. You said patient portals maybe aren't as utilized by the surgical procedural specialties because they can do their notes and then they need to go home. And when you're dealing with outpatient primary care, patient portals, I mean, they have full access now to the clinical team, and that's including us primary care physicians as well. So day and night, getting messages, generally well-meaning. I think, people are engaged more now in their care a lot of times, and maybe they're listening to different health podcasts. I mean, we tend to have a patient demographic that in Austin that are young tech workers, and they're listening to all the longevity doctors, and they want to do all these different things. But we get a lot of requests through the portal, and I think that can be a burden. I mean, it's good. We want to engage with our patients, but it's a lot. The volume can be quite high, and there's metrics around that too. I mean, you want to be able to respond to patients within a couple of days, but when you get the volume that's so high, it's hard to sometimes keep up with that and to do all your clinical tasks that you have to do related to an office visit. So another aspect that could be a challenge while you have patient portal access going on is just getting through the clinic day. Just moving patients um, through the clinic and having the time with them to spend to handle all of their requests. And so um, those are two things I can say right off the bat. Lots of pressure to get through the day, but that's where we need a good support, and not every clinic has that. Not every different medical environment has that type of support. And depending on the level of support that each clinician has, whether they have maybe nurse practitioners they can rely on, physician assistants, medical assistants, or other personnel, that could really drive burnout higher if you don't have that support there. That more and more of that's falling on the physician to complete and maintain.
Thank you. Dr. Shannon, you practiced internal medicine, you stepped away, and you have a big picture view. What do you wish leadership understood?
I love this question because leadership has such a big impact, and there's so much data now linking leadership behavior and physician burnout. And it's linked through in many ways, but one piece of it is around communication and feeling valued. And there are things and ways that leaders can behave and things they can say that will improve physicians feeling valued, and that reduces the risk of burnout. So we have data that shows this. So what does that mean? It means um, having a two-way conversation. So stepping away from top-down mandate type of leadership to one that there is conversation going both ways, and that physicians are involved with planning, designing, with giving feedback about the clinical implications of decisions that are being made. Um, there's a term, administrative harm, that I think is so important to understand, and it's those decisions made by administrators that have an effect on the patient or on the physician-patient relationship, and yet they're made in somewhere else, right? Some other office and or conference room, and they totally affect clinical care and the experience of the physician. And so I think the more that leaders really step away from that top-down mandate type of leadership and a more of a servant leadership, right? And really thinking about we're here first for the patient and then to support the people who take care of the patient. That is so important. And it comes down to communication and having that two-way communication. And there's data that shows that type of leadership, the servant type leadership, is more effective. So I think it's just getting the word out, and it takes a courageous leader to do that because it is different than what the traditional leadership has been. But I think it could make such a big difference.
Thank you for that perspective. So, Dr. Babanici, what keeps people practicing?
Oh, that's a great question. Um, because I've had the pleasure of talking with a few of my colleagues, the ones that are burned out, the ones that are recovering from burnout, and I see different things that make people stay.
We'll be right back. Take a listen to Dr. Demetrio Aguila, a plastic surgeon and otolaryngologist, who's helping lead our new private practice mastermind and community, a space for healthcare professionals who want to break away from employment and become a boss. Here he is in a snippet from season 2 of the series From Print to Pod.
Employers are starting to move farther and farther away from these hospital systems and these insurance systems. Over 70% of health insurance in the United States is paid for by employers. So as we see that move away from the hospital systems and away from the insurance systems, what we're going to see is a greater dependence on independent practices, on direct care, on direct contracting. When we get that tipping point, where the majority are no longer working with hospital systems and are moving toward private practices, then I think what we're going to see is they're going to be entrepreneurs because that's where the demand is going to be. And hospitals are going to stop, or they're going to significantly decrease the number of physicians that they hire. And so the jobs are going to be out in the private sector, in the private practice community. And so people will, whether they want to or not, will have to learn how to do this. I think ultimately what we're going to do, what we will see is a fostering of a culture of entrepreneurship, where we have people like, the four of us who are actually mentoring these younger people and telling them, look, you don't have to be scared. This is actually a great opportunity. There's a chance here for you to deliver better care more affordably that treats your patients better and treats you better.
Tune into the second season of From Print to Pod. Join the private practice mastermind and community in its introductory pricing and help us to establish autonomy in medicine. Let's get back to the show.
Oh, that's a great question. Because I've had the pleasure of talking with a few of my colleagues, the ones that are burned out, the ones that are recovering from burnout, and I see different things that make people stay. And one of the big things is honestly the joy they get to use their craft, their skills to help people heal and get better. And I think that's what keeps them grounded. Because for you to go to medicine and to train for those decades, it's not just because you want to make extra money, because we know that's been debunked many, many times that don't go into it for money. It's truly the heart to care for people. And so they have, from my personal experience, when I got burned out during the height of the COVID pandemic, I loved taking care of patients. I wanted to be there for my community as we were going through that terrible pandemic, but I also knew I had to be present at home. So you're kind of caught between this rock and hard place of really wanting to care for people at the lowest point of their lives. But you also know that it's not sustainable if you don't care for yourself. So I think one of the big things I've heard across the board is I like to care for people, and knowing that I have something within my toolbox that I can help people heal is what keeps people going and staying in medicine.
Thank you for your service. Shouldn't have to choose between your family and your patients like that, especially during the pandemic. Thank you for that. So back to you, Dr. Duhaney. If one thing changed, what do you think would reduce burnout the most?
Yeah, that's a good question. I would say one way to maybe reduce burnout. I liked what Diane was saying because working in an organization where there is leadership that interacts with us and we're trying to meet leadership metrics, and sometimes decisions are made and then they have an implication on patient care. Um, the clinical team wants to feel valued, and if the clinical team is not feeling valued, then they don't feel motivated to do the very best for the patient, and then the patient relationship then is in jeopardy, and it kind of goes downhill. So I think in my particular scenario, and in scenarios where there's a lot of employed physicians that work, if there is a legitimate feedback mechanism where the clinician does feel valued, I think that would help keep us in the game. If they understand what we're going through, that aspect is so important because a lot of times there are shows where decisions are made and It's there's no clinical leadership that's involved in that decision. But if there are clinicians that are at the table, even at that level, maybe they're not seeing as many patients, let's say, or seeing patients at all. If they have some idea of how that's affecting the clinical team, I think that would go a long way to reducing burnout. That's one thing. That's one of many things. But I mean, I like that idea that Diane had mentioned because I think that's very, very true. Because you could say get rid of the prior authorizations, and then the burnout would go that way. Yeah, but then there's also the patient portal, and there's also the quality metrics, and there's also you need to see X number of people. So there's a lot of that. But I think if there is that general value of the clinical team and what and acknowledgement of how hard everybody's working, I think that goes a long way.
Definitely. Well said. Dr. Shannon, back to you. Any advice for doctors going into internal medicine?
Oh, yes. What I wish I'd known.
We'll be right back.
We're so much more than articles in a magazine. We're networking, we're conferences, we're learning, we're growing. We're providing publicity for healthcare professionals today. Membership now free for US-based healthcare professionals. Go to doctorsonsocialmedia.com.
Back to our show.
Oh, yes. What I wish I'd known. I think what I wish I'd known is that you're human. And that sounds so simple and basic, but I know that when I started medical school and then training, when I look back now, I can say it was like I was shedding parts of myself in order to keep doing the thing, to keep in training. And I trained before there were any limits on hours. And so to keep up, I gave up hobbies, I gave up relationships, sleep, exercise, reading for pleasure. And I wish I had known how important it was to keep those, to keep who I am as a human, and that we deserve that. And yes, we make sacrifices, but we don't have to make sacrifices to an extreme. And I think it's easy to start that in training and then continue that way, and to make that shift and say, wait a second. Yeah, I had to make an extreme sacrifices during training, but do I still need to sacrifice to that degree? And what do I really want in my career? And I think it's also easy to start climbing ladders that maybe other people want or that look good, or that you think you should do. And maybe that's not the ladder you want. Maybe you want to be in academics or you don't, or you want to write a book, or you want to practice it with a certain patient population. And I think if you know that, great, go for it. But don't just do the next thing because you should. I think that's what I wish I'd known, and just to hold on to, I get to be a human. I get to sleep. I get to exercise and have relationships. And all of that is so protective from the stresses, right? But it's easy to let those whittle away when we're under pressure.
Such great advice. Thank you. So I have one final question. It's going to be the same question for each of you for kind of a take-home message for our listeners. The question is, how can we make internal medicine more sustainable? Starting with you, Dr. Babanici, how can we make
Yes.
internal medicine more sustainable?
I love that question, and I'm just going to piggyback off of what Dr. Shannon already shared. I think to make it more sustainable, we have to make it more humane. We have to make physicians human too. And I'm all for the people first philosophy. I know in training we were taught about patients first, and I understand the heart behind that because we have to take care of our patients, but it must never be at the detriment of the clinicians. It must never be to the point of self-erasure where you don't exist. Because I like to say that we are not immune from the conditions we diagnose our patients for. We are not we're not superhuman. We're human just as they are. There are studies that have shown, actually, a recent study I was reading that women physicians have a higher rates of mortality than other non-physician professionals. And when we look at the life that we live, especially in internal medicine, or even other parts of medicine, we are being asked to pour out of empty cups all the time. And so I go by the Thrive Whole concept, aligning with what Diane shared earlier of taking care of yourself, filling your own cup, fill in your own bucket so that you become that well that other people can draw from. So being human first is how we should practice internal medicine sustainably.
So vital. Thank you. Dr. Duhaney, how can we make internal medicine more sustainable?
Yes, that's a great question. I think you guys are right on it there. It's a lot of unlearning because I think the aspect of being superhuman is something that is, just built into us through medical school, residency, even with the work hour restrictions. That came out and it was 80 hours a week. And even then you're like, really? And just go, 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 go. Everything's for the patient. Everything's for the patient. The patient comes first. It's been mentioned. You're losing hobbies. You're losing relationships with others. You're losing yourself. You're not exercising. You're not doing the things that you need to do to thrive physically, mentally, spiritually. And the minute we start realizing, wait a minute, I don't have to be that person. I can still be a great doc. I can still care so much for my patients, my colleagues, but I need to have those boundaries. I need to spend time with my spouse and my kids and play tennis and, take a vacation and not have to worry about, oh my goodness, who's going to cover my patients when I'm gone? And I'm going to be checking my portal and no, 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 log off. And how we can support each other in that so that we're not making each other feel bad that female physicians, they take off time, they have babies, and the male physicians are like, oh, we have to cover. Like, wait a minute. We get to do some of that. We need to work together. I think there needs to be more collaboration from that standpoint because there's a lot of shame in medicine and we kind of the blaming and everybody's doing the turf wars. And why don't we try to figure out how we can all come together to take care of the patients, but take care of ourselves as we take care of the patients. So that would be my
Thank you.
assessment and take home.
That would be a great start. Dr. Shannon, how can we make things more sustainable?
Well, I'm going to agree with everything that my colleagues have said so far. And what I'd add to it is something about how we pay for healthcare, meaning really rethinking. And I think this is where we as physicians need to advocate for change. When there's so much focus on profit making and margins are thin, what I have seen happen is that there's less resources put into the people who do the work. And for example, when a physician is on vacation, why don't we have a float pool of physicians who are paid to come in and take care, kind of like locums, but just within that organization, there are physicians. The idea is when you're on vacation, you're off and your colleagues are not having to work twice as hard, right? Why don't we invest? Well, who knows why that, we've been set up this way financially, but I think that's the kind of thing that needs to change. And when and I've seen this over the past 5 years, the increasing pressure on making money, being profitable, seeing more patients, changing your template so you're seeing more patients, right? Coding properly, all of that pressure. I'm not sure exactly how we go about advocating for that to be different, but I think it's a really important thing to keep in mind.
Each of you have unique experiences and your voices are so important in this conversation. I want to thank each of you, Dr. Babanici, Dr. Duhaney, Dr. Shannon. Thank you so much for joining Burnout by Specialty Internal Medicine episode. Appreciate having you on the show. Burnout may be one word, but as we've heard, it's not one experience. This is Burnout by Specialty.